Okay, we might make a start given it's just turned half past and we know other people will join us as we're talking. So, as I mentioned, my name's Tim Shaw. I'm from the University of Sydney. I guess in the role I'm having with this webinar is that I've spent a long time working with ISQua over the years in their education and more subsequently I've been working with the Cancer Institute around implementation science through a number of translational cancer research centres that they fund. So today's webinar is actually a three-way webinar, or sponsored three ways. It's by ISQua. So I'm seeing there's a number of ISQua fellow candidates logging in, the Clinical Excellence Commission New South Wales, and the Cancer Institute New South Wales through the Community of Practice in Implementation Science. So it's with pleasure today that I introduce Ulfat Sheikh, who has joined us from University or UC Davis School of Medicine in California. So Ulfat is Associate Professor of Pediatrics and Director of Healthcare Quality within that organisation. Ulfat and I actually first met at the ISQua Scotland, I believe, and Ulfat was talking around how we can use different interventions, particularly around education and online learning environment, around quality improvement and implementation science. So what we're going to do today is Ulfat's going to run through some of her examples from her experience in the US. Then I'm going to quickly run through a number of kind of examples that we've used as well here, particularly using a methodology called QStream that a number of you I expect are familiar with online. It's interesting because I think Ulfat's come from coming from a kind of quality improvement curriculum type development, which certainly includes how you do improvement science within organizations, so how you make change within organizations. I guess I'm coming from the implementation side again, where we're looking at researching intervention around improving kind of quality outcomes in care. So, and we're tending to target nurses and doctors and so on. Anyway, so I think it's going to be a fun program. I certainly encourage you online to send posts in terms of questions. Obviously, everybody's muted with this many attendees. We obviously can't have everybody speaking, but I do encourage you to post to the chat, and you can post to everybody, then everybody be able to see your comments. And once we get to the end, I'll be asking questions, and Ulfat and I'll be having a discussion around the questions that are posted in. So, Ulfat, I'll hand over to you now, and I think we'll be away.
Great. Thank you, Tim. So good morning, everyone. I'm glad to be here at the University of Sydney. So Tim and I are at the same location right now after communicating for many months by email, Skype, etc. So our talk today is going to focus on web-based educational interventions. But I just quickly wanted to review face-to-face or non-web-based educational interventions that have been used quite commonly. That way we will sort of begin with a context of what's been done, what the gaps are, and what web-based education, what gaps web-based education hopefully can fill. If, for most clinicians such as myself, our email box and our mailboxes are filled day in and day out with educational material. In fact, medical education of the medical field, apparently the knowledge base turns around pretty briskly within 5 or 10 years. There's a renewed knowledge base, and trying to keep up with this educational material seems intimidating. We frequently attend large educational meetings, and there are obvious issues around knowledge gain and knowledge retention in a large didactic setting. And then what's more effective in face-to-face education is smaller educational meetings where there is the opportunity for discussion. So these are some modalities that are commonly used. A frequent method used lately has been educational detailing or academic detailing. And here you have someone really knowledgeable about the intervention, the evidence, approach a clinician, and then work directly with him or her on practice management and practice change. And then finally, what I will speak briefly about is using reminders or clinical decision support as a point of care for education. Frequently, reminders, when you think about them in the clinical setting, are usually chart stickers, posters in the examination or consulting room or the waiting room, computer-based reminders or recommendations. And effective reminders, when used for clinical decision support and education in a web-based setting are when you deliver these reminders at the point of care, they're tailored to individual patients. They address specific barriers that the clinician may have in terms of education or the patient may have in terms of education. And quite interestingly, since I come from an academic setting, these reminders are actually more effective in trainees than in practicing clinicians. So there is sort of differences in uptake of interventions such as reminders given based on years of training. So let me just start by saying that reminders at the point of care have been found to be quite effective in changing clinical behavior. There's a systematic review done in 2012 that shows that, and that's the reference if you want to look at it further. And then let me just briefly describe a study that we did at UC Davis trying to use reminders for education for our trainees, so for our residents, for our pediatric residents, using the electronic health record. The goals were twofold. One was to increase their knowledge of evidence-based guidelines related to pediatric obesity, and then our outcome measure was practice change in terms of counseling for pediatric obesity, diagnosis of pediatric obesity. So what we did is our electronic medical records were introduced about 8 years ago, and we worked with our EHR, electronic health record programmers, to basically insert a pretty prominent alert on the screen whenever a pediatrician saw a child whose body mass index was in the danger zone. So the child was either overweight or obese. And we tested this alert to make sure that the visual aspects of the alert were acceptable to physicians. And then what we did is, in addition to this alert reminding clinicians what an abnormal body mass index is in a child, which is this particular percentile, we linked the alert to templates, which not only helped documentation and thorough documentation, but also helped instruct clinicians on the kinds of things they needed to ask parents of young children. So, for example, his history around fruit and vegetable intake, screen time, physical activity, etc. And then we further link the alert to a checklist of lab tests, referrals, etc. that needed to be done, diagnoses that they could code for, etc. So again, the alert was not only meant to improve clinical care, but it was also meant to improve residents' knowledge around pediatric obesity. When we studied how residents did over a 6-month period, we found that the diagnosis of obesity improved, lab testing, appropriate lab testing improved, follow-up improved, and we found that counseling improved among these doctors. So we did believe that such an alert or clinical decision support delivered at the point of care online through an electronic health record not only improves knowledge, which we tested alongside outcome measures, but also improves practice. We did not test whether this actually changed patient behavior. We did that in a subsequent study. So, and I will be describing that study in just a moment. One of the things that's happened in the United States over the last 2 or 3 years is the requirement for quality improvement training in not only medical school and residency, graduate medical education, but also for practicing clinicians. So I'm a pediatrician and I renew my pediatric license every 10 years. When I renew my pediatric license every 10 years, I'm required to not just complete a closed book exam on pediatrics, but also demonstrate to my board that I have completed a quality improvement project that has changed my practice. So, and this is in addition to continuing professional development credits in general areas. So this is something that has come about pretty recently. And one of the issues with this requirement is all physicians are supposed to do this, not only pediatricians, physicians of every specialty in the United States. But the ways one might achieve this particular maintenance of certification credit for a QI or quality improvement project, the ways to get this are quite challenging. So just given time constraints, given ways in which clinicians can conduct QI projects in a substantial manner has been quite the challenge. So let me describe to you another study that we did at UC Davis that addressed not only obesity management practices, but also continuing professional development in rural areas virtually using a web-based setting. And the web-based intervention here was multi-point video conferencing and the use of an internet portal for discussion among rural practices. The clinicians in these practices might not have met at all if this particular community of practice or learning collaborative wasn't set up for them. So in this particular map, the blue star in the center of the map is UC Davis. That's about 3/4 of the way, 1/4 way down the state of California. This is a picture of the state of California. And the red dots were all rural practices that we engaged in this particular learning collaborative, which went on for 9 months. So this project was called ISQua, or the Healthy Eating, Active Living Telehealth Community of Practices. We had telemedicine equipment that these practices used for one-on-one patient care and consultation with UC Davis and Sacramento. And we thought about using the same equipment to deliver multi-point video conferencing and education to these clinicians, just given that they have this equipment and we thought there were other novel uses for the technology. So what we ended up doing was developing an intervention around monthly video conferences where each clinic team could see each other on the screen. And these video conferences, there's a very short 15-minute didactic component to them where we invited subspecialists such as gastroenterologists, cardiologists, nephrologists, etc., to talk about pediatric obesity and complications. But the other 45 minutes was training and systems improvement in the clinic. So clinic teams were taught how to assess their own practice, collect baseline data, go through plan, do study act cycles, reflect on their improvements, make further changes, etc. So it's just basic quality improvement theory. And we coach these practices on their QI projects over 9 months. We use the plan care model, and which basically includes various interventions in the clinic at various levels, nursing changes in front office administrative staff workflow, etc. And what we found that at the end of 9 months, we not only looked at clinic charts, we called up parents of young children that were in the practice and tried to see if children changed their behavior. So this was a combination of chart audits and parent phone calls. And we found that documentation for proper body mass index in obesity improved significantly, counseling improved, we found that documentation improved, and we also found that there were changes in nutrition and activity, positive changes, although short-term changes in children when we caught up with parents 3 months later to find out if they were eating better and exercising more. So this particular study showed us that it is feasible to run a virtual community of practice using a combination of video conferencing and internet portal for discussion among rural clinicians who otherwise might not have met. And then finally, let me talk about a third project that we did where we worked with graduate medical education trainees. So these are residents. They just finished medical school and are training to be pediatricians. One of the issues that has been raised recently is that health professionals in general are ill-prepared to address quality concerns. QI, quality improvement, occurs usually in an isolated QI department and rarely includes trainees who deliver the majority of care in teaching hospitals. And even if trainees do conduct QI projects, they're usually not aligned with organizational priorities or linked to clinical outcomes. So what ends up happening is they have trouble gaining resources for their quality improvement project. When they graduate and move on, frequently these projects just sort of fall off the list of priorities and aren't sustained. So given these challenges, why involve trainees in quality improvement? In the United States, trainees are frontline care providers. They spend more time in the hospital frequently than faculty. They have unique insights into system problems and they recognize variations in care. They can see that Dr. A practices a certain way, Dr. B practices a certain way. They're perfectly poised to pull out these variations in care and bring them to our notice. They successfully improve clinical processes and outcomes, and they are future healthcare leaders. So we do need to integrate them into all our QI efforts right from the time they begin their training. So in this particular project, we worked with residents on the team-based QI project. And this was a paper published in the American Journal of Medical Quality. It basically showed us that it's feasible to engage residents in very substantial team-based interprofessional QI projects that can be sustained and that can bring about patient-level outcome measure changes. So in the interest of time, so I will point to that paper that what the data there shows is their level of comfort with quality improvement improved with QI training, and their overall comfort in applying QI concepts improved. Now, the QI training we used in this particular paper was actually a combination of didactic training and using the Institute for Healthcare Improvement IHI Open School modules. So the IHI Open School modules are a free resource to students, and once they register on the IHI website, they're really very thorough. They're user-friendly. But one of the issues we found with using the IHI Open School modules was the completion rate of these modules was not substantial. So we had a fraction of residents complete them, but a large number of residents would begin these modules and never end up doing them by the end of their residency training. So we thought there were some obvious issues related to learner engagement, and which was the reason for this last experiment that I'm about to describe. It's trying to use educational gaming at the University of California. We have 5 health systems. I'm at UC Davis. The other healthcare systems are UCLA, UC San Diego, UC San Francisco, and UC Irvine. So QI teachers at each of these institutions got together and basically experimented using educational gaming to increase learner engagement and training around QI. So this particular first step was an introduction to quality improvement, and Tim will describe this in further detail, but just to sort of give you some introduction to the terminology that then Tim will expand upon. We used 2 concepts in education. One is the spacing effect and one is the testing effect in this particular educational program. The spacing effect is when you present information and repeat it over spaced intervals to improve retention. And the testing effect shows that long-term retention of information is significantly improved by testing learners on the intervention. And these 2 methods have been found in randomized controlled trials to be effective in improving long-term retention and even result in behavior change. So what we did was we worked with a company called QStream and developed an educational game-based quiz platform. Our residents at the 5 medical centers essentially engaged in a competition around solving a question bank of 20 questions in basic concepts around quality improvement. Each question literally took 2 minutes to complete. They could either complete these questions on their computers or on their mobile devices, on their smartphones. And then the questions were repeated based on the learner's answers. The questions were repeated twice before they were retired from the course in order to improve retention. And the whole module of 20 questions took about 10 to 15 weeks to complete. Again, we used scoring and leaderboards to increase learner engagement, and each UC campus had teams competing with each other. We were able to generate reports on a weekly basis for our residency program directors to see how the trainees were doing, and they received this in the form of customized emails. So the whole QI training has been developed as 5 modules, each comprises 20 questions. All 5 modules take a total of 10 to 15 hours to complete. And here are some screenshots. Hopefully they will show up well on your screen. But essentially the learner is presented with a vignette-based question. It's a clinical vignette. And depending on how they answer the question, they're assigned points. And the learner can view the top 5 learners, essentially top 5 scorers and where they stand with respect to these top 5 performers. One of the really interesting features in this program for us has been the use of the comment section by learners. So over here, a learner has posted a comment, Adrian, I'm coming after you, currently 5th place and rising fast. And this is a fun element we've seen here where learners actually putting in comments to goad each other on and to basically show us that this competition element is what's keeping them engaged. And then I can check on the status of learners and send a weekly update. Program directors send weekly updates if they so desire. This is a snapshot where I just want to see how the UC Davis campus internal medicine residency program is doing. And I can basically filter for that and look at individual campus performance. This tells me how each team at each campus is doing. So here you see LA Dermatology is scoring the highest. And then finally, at the end of the course completion of the course, a certificate is generated, which then I can keep for my professional portfolio. And we've had 300 house staff complete this module in this initial pilot. We're essentially continuing to test this now. And most of them have been residents or fellows. We've had some consulting physicians participate, and most of them have been internal medicine clinicians. Essentially, at baseline, an average of 46% of questions were accurately answered. And at the end of the course, the average mastery was 100%. Most learners agreed that the module provided them with new information, and this was an effective way to learn the material. There were some negative responses that showed us that the way we construct the question is key here. The construction of the question needs to be clinically based, needs to be grounded in a realistic clinical scenario that the learner might see, and also needs to not just test knowledge retention, but also application. So the learners liked that the program was straightforward, simple, easy to use. They liked the question-driven design. They loved the competition, but they preferred questions that contain quality improvement concepts versus those that contain statistical information. We found the repetition at some point to be overwhelming. A number of learners told us that, but one of our thoughts was this was a new way of learning for them, this type of spaced education with repetition. And we wanted to see if these issues were, the next time we presented a second module to them, if this was still overwhelming or if they had gotten used to the repetition element. They preferred closer spacing so they could be done with the module sooner. And they desired more active involvement by their program directors and chief residents and ongoing encouragement so that they could keep up completion of the module. So our conclusion was this is a feasible way to engage learners across 5 University of California campuses spread out across the state of California, multiple graduate medical education programs, simultaneously yet asynchronously. Most learners enjoyed this delivery method. And so again, we really believe that the best way to use such online training, you can use it as a standalone training program, you can use it to reinforce concepts taught in classrooms, but really to supplement hands-on QI activities where learners actually complete QI work and have this as their didactic component is perhaps the best way to use such training. It allowed learners to use technology that they already are familiar with, carry every day, use every day, such as their smartphones. They received immediate feedback, there was active learner engagement, and then there were customized reports that training directors could use. So again, these were the strengths of the program. And so with this, I'll end my description of our work. So again, I'm at the University of California Davis Healthcare System. It's based in Northern California. It's a part of the University of California system.
So thanks very much, Ulfat. That was a very interesting presentation. I think you raised a number of key issues around the role of online learning, how we blend different types of online learning. I think it was particularly, I think, some of the issues we're facing in terms of how we actually take a face-to-face learning environment. So we've done a lot in online learning, put it in an online environment where you end up with perhaps just a PowerPoint presentation, maybe with a quiz associated with that. But I think what's starting to emerge now, you highlighted it nicely, is a much more sophisticated approach to online learning that allows us to use different types of methods and blend them together and actually see them having impact on both quality improvement projects, as you're doing, what I hope to talk about now just for a moment, around some of the implementation science kind of programs that we're undertaking as well. So what I wanted to talk about briefly was just around this program called QStream, because it's really intrigued us in terms of its impact in the online learning environment. So I came across QStream when I was working in the States a number of years ago, and it was developed by a surgeon there called Price Perfect. Perhaps in a typical surgical way, he took online learning and cut away what he didn't think was very useful and was left with this QStream, which was this program that sends out case-based learning scenarios in a repeating pattern. And what he's found is that if you repeat this learning, you get a massive increase in knowledge retention. But what him and groups like our group now are starting to do also evaluate is the fact that this can also have impact on directly on patient outcomes in evaluation programs that we're running. So what I wanted to do was just run through a couple of examples of this quickly. And the first image I've just got here is from perhaps the reason I came at this is that I think that traditionally a lot of online learning has been pretty boring in its application. It's perhaps been more like image A rather than perhaps image B, where you've got a lot of happy people engaged in the process. So we've been really interested in how you can make learning and quality improvement much more engaging and interesting. So the first program I wanted to talk about was one that we ran, an internal orientation to safety and quality at Mass General and Brigham and Women's Hospital. We ran this about 4 years ago, where we ran it across all the incoming interns at those hospitals, and we were comparing it head-to-head with a program called HealthStream, which is a more PowerPoint-based program where it's associated with a PowerPoint quiz. So the way we structured this was to create a number of cases around key challenges that young doctors have encountered or likely to encounter, present them with those cases, and then get feedback once they answer the case. It's really quite a simple program. What we found in an impact sense was we had about a 75% completion rate amongst the residents that went through the program, and then we took another 140 of those in a blinded study through a simulated environment around central lining surgery, a small focus program, and what we found was a surprisingly strong trend towards QStream, or space education, as it's called then, amongst the residents that had undertaken the QStream program. And then we found that when we compared their performance in the simulated environment, there was a higher significant, particularly around surgical residents, there was a highly significant impact on their behaviour. The next program I wanted to briefly mention was a larger study we did. I did this with colleagues. It was led by Professor Dan Phillips, who's a palliative care nurse and a PhD student. We co-supervised Nicole Pennicker, and we were looking now more at how QStream could be used around a quality question. In this case, how we could actually develop a study to look at improving pain outcomes for people associated in palliative care or oncology wards. So we did a study initially. So the clinical problem we identified was that there's a lack of pain assessment and screening, which leads to poor outcome of management, and there's few interventions targeting this. So the study we developed was 2 phases. The first phase was a study amongst a small palliative care unit within Sydney, and then once we got positive results of that, we made it a larger multi-sector pre-post-test trial of the intervention. The results we found with this, again, were quite significant. With the smaller phase 1 study, we actually had impact on the pain outcomes of the patients that were treated by nurses who've done the program, and a highly significant increase in sepsis. In the phase 2 study in the oncology ward, we reinforced the knowledge improvement and impact on the system. Unfortunately, we couldn't measure whether we'd impacted on pain scores because the pain isn't routinely assessed in oncology ward, which is obviously a gap in practice as well as in the study. The final part that I want to talk to you about is one that we ran at Brigham and Women and Mass General Hospital recently, where in this case we had a competition between all the nurses on wards within one hospital, and then within Mass General we had a competition within a single unit or ward. In this case, we de-identified all the nurses and gave them rock band names for fun, but also so that people didn't feel they were being singled out, they weren't asking the questions correctly. And what we found was we had a really good level of competition amongst the nurses, and they'd actually self-identify with their band name, which is really interesting. Then we also had the competition between the wards, and I think what we found here that was really important was that different units interacted with the learning methodology in different ways. So if you had computers in your workflow, then you tended to use those computers. You tended to really engage with the program, whereas with emergency we had lower engagement with the emergency department because they would use computers less and were much more fragmented with how they approach running around and so on within their daily lives. In terms of the results, we got about a 70% uptake, which is very good across hospitals. And then depending on the department we were looking at, we got about a 40 to 80% completion rate. And as I was mentioning, it worked better in some wards than others. It was really interesting to me to start to see the really nuanced differences between the different ways people engage with online learning. I'll just finish here with an image now of the winning ward, just to show, I guess, the kind of level of enthusiasm that online learning can generate if you actually embed it within the unit. And perhaps we can discuss some of that in the questions. The nurse in the middle there was the winning nurse, and then the cake, the whole prize was for a cake. But the winning unit was extremely excited about having won that prize. So I'll stop there. We encourage people to post comments and so on. Thank you. Okay, so can I just ask you again in terms of what do you think are the key success factors you have in the kind of online learning programs that you've developed?
So, well, the key success is one of the things we found, the two programs that we found that were most successful so far. So the first program was ISQua, the Healthy Eating, Active Living, Telehealth Community Practice. And we found that the blended learning approach worked immensely well. So we had clinicians engaged in conducting QI projects so they could practice the skills they were learning. We also saved a great deal of time by moving the didactics to an online platform. So for the purposes of ISQua, we used some IHI Open School modules, some recorded webinars that we had prepared by ourselves. So essentially using asynchronous methods for the didactic component and then basically using all the face-to-face time we had for actual project implementation and practice was what was the most helpful. With the QStream program, what we're finding is that especially with junior doctors that are really comfortable with technology and are on their smartphones anyway, so why not leverage that for education? We found that particular program has, at this point, again in its pilot phase, it shows promise in increasing engagement in getting learners to actually complete the training program versus incompletely or partially finishing the training. So again, the key success factors have been having learners practice all their skills and not just focusing on knowledge transfer.
Okay, that's good. And then, I mean, Ulfat, would you kind of comment as well on, I guess in Australia, we're certainly heading towards looking at having more and more kind of mandated online learning as well. And I know in the States you have a lot of that in terms of joint commission requirements for online learning and so on, to actually get through a kind of large body of work around quality improvement and so on. Would you be able to comment on that in terms of, I mean, how do you think that fits with what you were just saying then about the kind of impact of actually getting really quality kind of programs up?
Yes. And unfortunately, the requirement to train clinicians in a large number of required courses has led program developers to sort of take the quick and easy route and make most of these programs fairly passive. And, so I am required to complete at least 5 or 6 of these every year. And again, the level of engagement I have, what else I'm doing while I complete this program is, this just bring to question the validity of this particular method of learning. So most of what I do are recorded webinars. I'm supposed to complete a short quiz at the end of it. I'm fairly certain I can complete the quiz and pass, even if I don't complete the whole program. So again, sort of getting through all of these trainings has been the focus here, not the journey, but the end result. And again, using just more innovative methods that leverage psychological educational phenomena such as spacing, testing, using competition, which seems to be sort of this innate characteristics in all the clinicians we work with. I mean, they're naturally competitive people, and sort of leveraging that psychological element for education has been fun. Using novel programs, again, if we keep using programs such as Q3, I'm not quite sure if the novelty wears off after a while. At this point, it's quite novel, which is what is engaging a lot of learners. So again, moving from the outcome of program completion to the outcome of learner engagement and knowledge retention is where online education needs to move to now.
Thank you. So we have some questions coming in. I'd encourage other people to post. So we have a question from, I apologize, my pronunciation, Fatul Hatami. Is talking about what are the challenges in implementing online education programs, particularly the educational gaming exercise and studies conducted. I mean, I might take that one first, and then maybe you can have a chat too around that, Ulfas. And I think the challenges, I think one of the challenges I found is that to make online learning really kind of work actually takes quite a lot of work. So it's quite easy to create a program that you can just send out to lots of people. But if you really want to make it crafted, then you do have to look much more at the kind of the quality of the cases that you're asking, that they're really focused around the kind of user groups that you're targeting, that they're very contextually relevant to those individuals. I think you also, I think the key thing is you actually have to have somebody that's going to manage the program. So if there's a competition, as you would have found yourself, that you need to have people engaged in the process. You need administrative people that are actually getting the teams together, organizing them. And then you also need to have the buy-in, I think, of the people that are working with the team. So in the residency program, you need the residency directors, or in Australia, the directors of physician training, for instance, endorsing, engaging with that program. In the nursing programs you've run, it's been very important that the director of nursing is engaged, and then that each of the unit leaders within the nursing facilities are also engaged in that process. So I think that's very, it isn't, I think this is one of the challenges that we have to put the effort into creating a kind of enclosed quality program. Would you have other comments on that, Ulfa?
Well, again, one of the themes that kept coming up when we had learners complete the narrative portion of our evaluation survey was the construction of questions and how important that was. So again, when you're constructing questions for question-based online learning, it really shouldn't be, a bunch of doctors and nurses sitting around a table who aren't really trained in educational theory. You really need to engage professionals that work in question development around that. Again, the learners much preferred the realistic clinical vignettes that we had developed, and choices of answers that showed application versus choices that showed epidemiology or numbers. So, and then one of the really critical elements of our question was the narrative section. So the narrative section of each question described why each correct answer was correct, why each incorrect answer was so. It pointed learners to URLs where they could click to read PubMed citations or other evidence in the literature. There were links to videos, short videos that learners could watch. So again, just using the narrative section as richly as possible for learning was critical. So learners did enjoy the clinical application of all of these questions.
Okay, great, thank you. There was another question coming through the chat saying, how are the programs promoted? What were the most effective promotional and advertising modes? Maybe again, if I start with that and then you can carry on. I think again the the key one we found with this is that they're actually promoted through channels that the people will respond to, if you like, in terms of it coming from leadership, the leadership organisation to actually encourage people to take part. We found that much easier and more having higher impact than just sending out blanket kind of advertising across a whole range of different people. For instance, we run a program with Cancer Australia around breast and lung cancer diagnosis, where we've had probably 150 to 200 people going through that program, which is good, but that's been sending it out through the colleges. Whereas if we, with the programs we've done at Brigham and Women, if you actually have the hospitals engaged, then you've suddenly got 400 people enrolling in the program immediately. So I think that's more important. I don't know if you have comments on that as well.
Yeah, so I do, and again, involving the program director that's directly in charge of particular learners' education. So us coming in as ISQua education people, advertising this would not have been successful. But using, for example, the pediatric residency program director to promote this to pediatric residents was key. Again, at the end of the program, one part of the evaluation showed that learners desire more high-touch sort of engagement from their program directors. So again, most of the communication was in the form of emails that program directors sent their learners. The learners did voice that if there was more personalized engagement, that their courses were to display here, sort of, just again discussing this learning program at one of their regular learning meetings, sort of keeping up with encouraging them. They would really have kept up because again, this is sort of our program was a 10 to 15-week program, and we really need sort of higher touch approaches from program directors to keep learners on board.
Thank you. So look, I think we have another. Okay, this is an interesting question that's come in. How effective do you think these programs would be for lower level workers with less access to technology? And I think this is certainly something we've been considering. Obviously, there's a certain level of technology requirement that people need. They have to have access to computers potentially, and we have found with some of our nursing programs that we've been running that we've actually put computers on the floor for nurses to use, whereas with the residence programs we found that they're more likely to use their iPhones and tablets and so on. So I think there's a couple of interesting with workers that are more perhaps not in the nursing and medicine side, perhaps some of the auxiliary stuff. And we're looking at this, I think, particularly perhaps around aged care, where you've got a large component of the workforce that doesn't have professional qualifications. I actually think that there's a real opportunity for programs like QStream and others to reach out to that workforce, because it's a very simple system to use. You can use email that most people can now, then you can use these types of programs. And it's very easy to create cases that are relevant to different levels of people. So with the QStream program, all you get is a short case scenario and then you answer it. So that can be set at different levels and in different languages potentially as well, if you have a large cohort of people that are non-English speaking background. But I don't know if you could comment on that too, Ulfa.
Yeah, so again, Jim's comment that you can use email, you can use QStream as perfectly right on. Again, and we do see residents and students using their iPhones and Android tablet, sort of all of those technologies more frequently than email. One thing though is the frequency with which you check your email is probably the key factor here. The scoring system is designed so that the sooner you actually tackle the question and sort of, the speed at which you answer the questions correctly contributes to your overall score. So if there were people with access to email that access them less frequently, then, their ability to score a high score is compromised. So if, for example, an organization is using email for their regular communication and there is the expectation that you check your mail frequently, I think the program such as this would work just fine using a regular computer.
It was interesting at one of the Brigham hospitals, and that they were another side product of this program was that they were trying to encourage people to use their email. So they were hoping, and I think this is happening, that these kind of programs encourage people to use electronic communication across different levels. So we had nursing support aides doing the program as well. Look, I think we're nearly through. We've just got a couple more questions. There's one, excuse me, there's one from Kathy who's asking, what would happen if an answer indicated poor or dangerous practice? That's an interesting question, and I think, I mean, this is a challenge with any learning program. I mean, one of the things we've been looking at with QStream and some of the places we've been using it is actually as a way to judge your workforce competence around key areas. So in that kind of an issue, I would think that if you were starting to see that people were answering the questions in a particular way, then that gives you an immediate feedback that you should be perhaps developing programs to target that practice in other ways as well. The last question that we've got here is from Jan, who is saying, was consideration given to interdisciplinary training in quality improvement? Have you used this interdisciplinary ALLFAT at all in your learning program?
Yeah, so the Health Corp Learning Collaborative was designed as an interprofessional program. So we require that each clinic team have at least one physician, one nurse, one front office staff, and one administrative leader. So that was built into the design of the program. With the QStream gaming platform, we tested this primarily on physicians. We've had nurses volunteer to complete this on their own. We've had a couple of physical therapists and nurse practitioners complete the program. We haven't mandated it for the non-physician group. So in that respect, it isn't completely interdisciplinary right now.
Okay, thank you. So look, I think we'll wrap up in a couple of moments. I mean, I thought maybe I could say a couple of words, and if you have any just final statements or comments to make. I think it's been a very interesting presentation. I thank you for that. What I'll do is, it seems a couple of people couldn't see the slides progressing from me. So if that was the case, if they haven't recorded, I'll just repeat my slides with the images there. Although I have to say that I don't use a lot of slides, so you didn't miss much. If you were listening to me, you would have seen the presentation. So I guess for me, what this shows is I think there is a real opportunity to use online learning in a whole variety of ways in both implementation science and quality improvement. But I don't think organizations should underestimate what's needed to actually make them really work on the ground. I think it's very easy to say that we'll create this program and just let it go out there. But it's very hard to say whether that kind of a program is going to have impact and track its kind of impact. I think what I'm interested in is how we start to develop programs that are really targeted, that we can really look at how they're having impact and follow that impact through. And I think in the implementation science space that we work in, that's really important, that we can then start to track this learning through to actual impact on patient outcomes and obviously the kind of behaviour of the clinicians we're targeting. So, and I think, again, I think we're in early days around online learning. There's a whole part of hype around MOOCs and other methodologies. So I think over the next 5 years, there's going to be a real evolution in terms of the quality kind of programs that are out there in an online learning environment. I think we're only just starting to begin to see them emerging through methodologies like QStream and others. Do you have any closing comments, Ulfa? Yeah,
so one closing comment I have is just, as a clinician, I had the tendency when I first set up designing this particular question-based program to sort of I have the false perception that I could just sort of sit down with my physician colleagues and hash out a bunch of perfectly understandable and useful questions. And again, I just wanted to caution people that were developing these type of question-based learning programs that you really need to partner with educational specialists and professional question developers. Really, they point out nuances that you may not have even picked up. So again, not just being interprofessional with respect to the kind of clinicians involved, but being interprofessional with respect to the kind of question developers that you get on board to develop your program.
I would echo that also as well. So James in my team and a number of our members have gained a educationalist background, and they certainly work with the content matter experts to generate quality material. And I think that's another mistake that people make in online learning, is that you can just go ahead and just put out a whole pile of stuff without having a good educational underpinnings behind it and quality in that respect. So, okay, well, look, thanks very much, Ulfa, and that was an enjoyable webinar, and I hope we can run another one in the future, but we'll stop now, and I thank all the participants for being online. Thank you.
Thank you so much. Have a good day.